Welcome to the Advancing PAH Care video series. This series includes key opinion leaders who discuss new information in the 2022 ESC ERS Treatment Guidelines for pulmonary hypertension and how these recommendations can be incorporated into clinical practice in the U.S. Some of the topics to be covered in this series include risk stratification, the right heart beyond pressure, ESC ERS treatment algorithms, and individualized patient care. With support from UT, the PAH Initiative provides non-branded disease education for the PAH community. The initiative worked with PAH experts to identify the content for this program.
I'm Dr. Paul Forfia, a cardiologist and professor of medicine and co-director of the Pulmonary Hypertension, Right Heart Failure, and CTEPH program at Temple University Hospital in Philadelphia. And I'm joined today by my partner, Dr. Anjali Vaidya.
Hi, I'm Dr. Anjali Vaidya, also professor of medicine and cardiologist at Temple University Hospital in Philadelphia, co-director of the Pulmonary Hypertension, Right Heart Failure, and CTEPH program.
In this program, we're going to discuss right heart parameters, echocardiography in PAH, how these findings impact care decisions, and how echocardiographic findings are implemented into the updated ESC ERS guidelines. Dr. Vaidya, when we think about echocardiography, what are some of the echo findings that you think about when you're suspecting a diagnosis of PAH?
When I think about the views on an echo, one of the most helpful is that apical 4 chamber, sort of that money shot for pulmonary hypertension. And what we're looking for on this view is really evidence of the size, shape, structure, and function of the right heart parameters. The RV to LV ratio is enlarged, greater than 1. That's very suspicious for pulmonary arterial hypertension. Speaking of chamber size, the right atrium can also be assessed in size there, which can be helpful down the line even in our risk assessment. We're looking for the presence of a pericardial effusion in that view, which can also be a sign of very advanced disease and high-risk assessment in PAH. And then we're also looking for things like right ventricular hypertrophy, which is a sign of chronic afterload to the right ventricle, and an open RV apex, that angle of the RV apex being open rather than narrow. And that specifically is a marker of elevated pulmonary vascular resistance. Now, other views on the echo that are also very helpful, the parasternal short axis to the mid cavity of the LV, where you're looking for that septal flattening, that D-shaped septum. And that's what's traditionally described as septal flattening, reflective of RV pressure overload. But of course, what we know is it's really specific to afterload or that elevated pulmonary vascular resistance that you would see in PAH. The other thing on echo that's really helpful in that initial diagnostic assessment is the pulse wave Doppler in the right ventricular outflow tract. And of course, as you know, we're looking for that notching or that reduced acceleration time, both of which are very predictive of a high PVR in PAH. Now, all of that describes looking at the pictures directly, the images for echo, but you can also use routine echo reports to predict hemodynamics and help in the diagnosis of PAH as well. So there's something called VEST, the virtual echo screening tool that we published years ago, looking at routine parameters on echo and coming up with a simple score to predict if the pulmonary hypertension is due to left heart congestion, pulmonary venous hypertension, where we would expect things like an enlarged left atrium, an elevated E to E prime ratio, a numeric quantification to predict left heart congestion, and the absence of septal flattening. The flip side on a VEST score would be features that would give you a positive score, such as a normal left atrial size, the presence of septal flattening, and a low E to E prime. And a positive VEST score is extremely predictive of pulmonary arterial hypertension. So echo can be used a lot in the initial diagnosis of PAH. In addition to echo, though, how do you use right heart catheterization in your diagnostic assessment of pulmonary arterial hypertension, but then also over time in your risk assessment?
Sure. So as we know, in order to make a formal diagnosis of pulmonary arterial hypertension, it is required that we obtain a full hemodynamic interrogation through invasive right heart catheterization. And this allows us to measure pulmonary artery pressure, right atrial pressure, left atrial pressure, cardiac output, and then derive pulmonary and systemic vascular resistance. And so when we think about how we use right heart catheterization at the baseline diagnosis, the things that I'm most interested in, how high is the PVR, and how affected is the cardiac index, and how elevated is the right atrial pressure. It's not surprising to know that on serial assessment, PVR, cardiac index, and right atrial pressure are also very important to follow in patients serially on therapy. In fact, one of the most important parameters to see on follow-up hemodynamic assessment of a patient is what their cardiac index is on PAH medical therapy. This is far more prognosticating than even their baseline cardiac index is. Dr. Vaidya, how do you use echocardiography to serially assess patients once a diagnosis of PAH has been made?
So on the echo, we're looking at RV function, TAPSE, for example. We're looking at more extreme metrics that represent really severely decompensated right heart. So when the right heart is chronically congested and impaired in function, and you have impairment of venous and lymphatic drainage via the coronary sinus, you can develop that transitive pericardial effusion. So right atrial size actually has been shown to be predictive of risk in pulmonary arterial hypertension. To some extent, we're looking for reversal of some of those other diagnostic features, like improvement of that septal flattening, for example, and the overall improvement in RV morphology. But importantly, not just the assessment of the right heart on echo, it's worth talking about the frequency of use of echo in the risk assessment in PAH. So we've learned over the years, and the guidelines, the ESC ERS guidelines also emphasize this, that echo should be used more frequently than it previously had thought to be. And so at least every 3 to 6 months of using echo in risk assessment for PAH. And we've learned that frequent monitoring with echo actually improves our ability to accurately risk assess patients. Now, in addition to the echo and the hemodynamics in terms of the risk assessment in PAH, how do you incorporate both of those things in conjunction with some of the other important clinical parameters such as 6-minute walk distance, functional class, or NT-proBNP?
In order to best answer that question, I like to go back to thinking about the hierarchy of living systems, and I think about organs, organ systems, and organism, right? And so the organ that's affected in PAH at the outset of disease is the lung and the lung circulation. And as that lung circulation is diseased and the pulmonary vascular resistance goes up, that affects the right side of the heart. That's your organ system, right? It's the lung and the heart. And so I think of that as the leading indicator of the disease. And then I think about things that stem from that and happen later. What can happen next? Your BNP is going up. What can happen thereafter are things that are a bit more pathophysiologically removed from those kind of core pathophysiologic changes, like a person is saying, I'm more short of breath when I'm walking. Their functional class will rise. Their 6-minute walk distance may go down. Ultimately, if those abnormalities persist, a patient may actually transition into having clinical right heart failure. You'll start to see fluid retention, and even the patient may become hospitalized from decompensated right heart failure. And so I like to think of the cardiac imaging findings as a leading indicator, and then some of those more further removed parameters as lagging indicators. As you know, one of the key goals in the management of PAH is to actually get the right side of the heart to as close to normal in size and function as possible.
So that's a really nice summary and actually ties into what we've often said about take a look at the heart to see what's happening in the lungs, which of course is then a predictor for what would happen to the patient entire. So we've talked about a lot of components today of the right heart, and just to summarize, initially really looking at the echocardiogram to use parameters to help make the diagnosis of pulmonary arterial hypertension. We've talked about the hemodynamics that are really important to support that diagnosis. And then shifting gears into risk assessment, we've taken a bit of a deeper dive into looking at how the echocardiogram can represent markers of risk from the right heart, and also how you use those complementary hemodynamic parameters to help predict risk in PAH over time. And so it's important to partner with our sonographers and our technologists to ensure that they're able to obtain high quality, comprehensive echocardiography to make these assessments that we discussed. And it's important for the physicians to know that if we don't have access to that kind of echocardiography expertise, then per the guidelines, it really would be very important to refer patients to accredited centers of pulmonary hypertension expertise who can then have access to that quality of echo. And so we've had a wonderful conversation talking about pulmonary hypertension and the right side of the heart and how it's been incorporated into the most recent ESC ERS guidelines. And we're really delighted to partner with our colleagues who are continuing that conversation of how to use the ESC ERS 2022 guidelines in the clinical care of pulmonary arterial hypertension.
Thank you for watching. This program is part of a series of videos about how PAH management has evolved in recent years. Topics covered in this series include the importance of hemodynamics, the role of risk assessment, the PAH treatment algorithm, and considerations for the treatment of PAH. For more information on PAH, please visit resourcesforpah.com.